This is Heart Rhythm TV. In this month's featured article, which comes from the Republic of Korea, we're joined by Dr. Seung Hyun Lee from Seoul, Korea, and Christopher Ellis from Vanderbilt to provide us some insights and some commentary. Welcome, Drs. Lee and Dr. Ellis.
Hello, everyone. It's my great honor to join this valuable discussion in Heart Rhythm Society. So I hope this discussion and debate will be very fruitful for every cardiologist and cardiac surgeon. Thank you.
So Dr. Lee, you're the corresponding author on clinical benefits of concomitant surgical ablation for AFib undergoing mitral valve surgery, a national cohort study. This is a large study, over 9,000 patients in an 8-year time span, and it's observational with real-world data. Can you tell us a little bit about why your group was interested in this question?
Actually, in the Asia Cardiothoracic Surgery Society, there were no specific recommendation for atrial fibrillation ablation during concomitant mitral valve surgery. So we have to follow the STS or AHA-ACC guideline or EACTS. So this study was conducted with the largest atrial fibrillation database and complete follow-up data from Korean National Health Insurance System database. So therefore, this study may be provided the current status and clinical outcomes of surgical ablation of atrial fibrillation in patients who had undergone mitral surgery in South Korea. And finally, we want to make our own unique recommendation or guideline in Korean Cardiothoracic Society, such as JCS, Japanese Cardiothoracic Society, reported in 2019. So, yeah.
Very good. And the question that you were asking was really looking at hard endpoints with May's procedure during mitral valve surgery, and that was repair or replacement. Yeah. Can you comment a little bit about the endpoints that you were looking at and the hypothesis that you were questioning?
Yeah, as you know very well, the May surgery needed some additional time during mitral valve surgery. So most cardiac surgeons have some fear to consume their surgical time for arrhythmia surgery during mitral valve procedure, and the additional time can make some hazard clinical outcome for mitral valve surgery patient. However, from many reports and many studies, we already know about the benefit of a major surgery, and the long-term clinical outcome of major surgery can give a beneficial clinical outcome to the concomitant mitral surgery population. So my process is major surgery consists of rhythm surgical ablation, consists of some left and right ablation region plus left atrial appendage dissection or isolation. So the most important procedure, I think most important procedure is left atrial ablation. The simple left atrial ablation can prevent some hazard thromboembolic event without any additional ablation surgery. So I think the additional major surgery during mitral valve procedure can give a beneficial clinical outcome to the in terms of long-term follow-up clinical outcome during follow-up period. So
that's great. And before we get to the results, I just want to bring Dr. Ellis into the discussion here. Chris, do you think that this whole concept of looking at surgical data and looking at these hard outcomes of like mortality, bleeding, and stroke, is that something that's been done in the surgical literature, or is this something that would definitely advance the field just on first principles?
Sure. Yeah. I mean, first of all, just May's, even though it's in the STS guidelines, as was referenced, as a 2A indication for basically treat AFib, it's a good idea. it's vastly underutilized in the United States. I'm sure we'll discuss that. 2 trials have been done that are randomized trials and, published in sort of premier peer-reviewed journals. That's the LAUS-3 study and Dr. Gilinoff's study of 2 different methods for surgical ablation. And at the time of mitral valve surgery, neither of those detected any mortality benefit. Really, the ablation trial was just to look at, AFib success rates. Okay. LAUS-3 did show significant ischemic stroke reduction by managing the left atrial appendage at the time of sort of any cardiac surgery, not just mitral valve surgery. But limitation on that, of course, is most of the patients still remain on anticoagulation. And so teasing, and you really didn't know if the appendage closure was complete, which is a huge factor. I think also in these kind of trials, observational studies, there's no imaging to confirm that what you intended to do with the appendage was complete. And also kind of as we know from our ablation studies, right, the aggressiveness that you monitor for recurrence after ablation is going to greatly affect the results in terms of AFib-free survival. And then presumably some degree of AFib burden reduction should correlate with hard endpoints. So the fact that we got, I think, hard endpoints in this study is really important. But it's like, it gets confusing, right? Because every time we try to do a clinical trial to prove that ablation prevents strokes or that ablation improves mortality, we are disappointed. Now, that's because your trial is very restricted in the patients that you're looking at. So this kind of data is more real world. And I mean, the reality is at some point, if you actually track everybody, then even if it's observational, it's real. And so the results, you can't say, well, it's not a randomized trial. If every patient treated is followed and we can have a reasonably good comparator group, I think without a randomized trial that this looks like it does significantly impact the hard endpoints that Dr. Lee was looking at.
Well, thank you, Chris. So Dr. Lee, why don't you take us through figure 2, which
Yes.
really shows 4 graphs of your composite endpoints and individual endpoints.
Yes. So I will now I will explain my study's brief method and result from the figure 2.
Mm-hmm.
And data on subjects were retrieved from the National Health Claim Database established by National Health Insurance Service of South Korea. So we identified subjects who were diagnosed with atrial fibrillation from January 2009 to December 2017. So overall number of 1 million patients. Subjects who had undergone mitral valve surgery, replacement or repair, and were older than 20 years were included in this study. So finally, 9,504 patients were enrolled. And we need some propensity score matching because we have to exclude the selection bias. So propensity score matching was performed to reduce bias from the difference in subject characteristics. So after matching, 3,376 pairs were retrieved and all baseline profiles in the matched cohort were well balanced. So, and after that, we identified the risk of death, cerebral vascular accident, which consists of hemorrhagic and ischemic cerebral vascular event and major bleeding event, and the composite outcome. Composite outcome means the death and ischemic stroke, hemorrhagic stroke, and major bleeding, and in the control group and in the major group. So each outcomes was defined as hospitalization with the corresponding ICD-10 code system. So as you can see the figure 2, so after propensity score matching, we can see the superiority of the MAGE surgery group compared with the non-MAGE group in terms of overall composite event. So p-value is very significant, and single death event also very superior in the MAGE group compared with the non-MAGE group. And composite cerebral vascular event, including ischemic and hemorrhagic, we can see also the very superiority in the MAGE group compared with the non-MAGE group. And finally, the major bleeding event, also we can see the MAGE group superiority compared with the non-MAGE group. So overall, in terms of overall composite and major risk components and risk event, we finally found the MAGE group show the clinically superior than the non-MAGE group.
Beautiful. So if you, at face value, if you look at these curves, it really seems like we should be telling our surgeons at the time of mitral valve repair or replacement, which there's different representation within the group for the readers that will be looking at the journal, that they really should be considering arrhythmia surgery or MAGE at the time. Now, Chris, if you're going to have reductions in these hard outcomes, it may be because you're actually just maintaining rhythm. You're preventing heart failure, although there isn't any echo data from here, or potentially you're managing the left atrial appendage, but we don't know the percentage that are actually having their left atrial appendage occluded, clipped, removed. So what cautionary limitations would you tell our viewers when they're interpreting this data and reading this manuscript?
Yeah, so I think that the fact that only about 15 to 20% of people at a year post-procedure were on anticoagulation, that's an important factor. So like, you don't have a big variation in anticoagulation use between the groups. So the effect of that on hard endpoints is not clear, right? Like, we didn't get a hemorrhagic stroke reduction, but it may just be because there wasn't that large of a percent of patients being anticoagulated, and particularly with warfarin. That was excluded, right? They took patients with mitral valve mechanical replacement out because, you know, those patients have to be obligatorily on warfarin. The other is, like you mentioned, no ejection fraction data, don't know AFib burden reduction, or, you know, any kind of quality of life scores. I mean, that shouldn't probably affect hard endpoints. And then again, the suitability of closure of the left atrial appendage, which I really think is huge, because when you look at like PROTECT PREVAIL data, 5-year data show, right, cardiovascular mortality reduction. However, when we look at the AMULET IDE data at 18 months, if you had a 3 millimeter or greater leak or 5 millimeter or greater leak with Watchman, like the stroke rates double. So you lose the protective benefit. So, you know, if it's like half of these were incomplete closure, and that was the reason for the mortality reduction, maybe the real benefits actually significantly higher if you only analyze patients with complete occlusion, and then compare that, you know, to a group of patients who you left them on anticoagulation, or who had their appendage, the appendage wasn't managed, but they were in sinus rhythm and anticoagulation was stopped anyhow. So
yeah, so it may be that a lot of the mortalities you're talking about with left atrial appendage data is just getting people off of blood thinners. And Dr. Lee's group did show that there was a statistically significant reduction in the amount that are need Coumadin and warfarin. So that is possible, although some of the electrophysiologists can still dream that maybe sinus rhythm maintenance is what's preventing heart failure, and like EAST-AF, you know, rhythm control is really what's delivering the goods. Although I think it's hard to glean that insight from this study. So
well, I think that like the AFib burden thing is, and heart failure is very dynamic, right? Like you see it all the time. EF drops, patient goes under general anesthesia, their appendage fills up with smoke and the atrium looks horrid. You give them isopril, perk up their ejection, and the smoke clears. So there's like the AFib and heart failure link is very dynamic. And if you eliminate the sink for thrombus formation from the appendage, then perhaps these times when you flip in and out of AFib and your EF drops and, you know, the atrium gets smoky, you don't form giant thrombi and die from a stroke, because really the principal source of that has been removed at the time of the mitral valve maze procedure.
And Dr. Lee, you did the mechanical mitral valve replacements are included in this data set.
Yes.
Because I see that 66% of patients had a mechanical
66% patients
prosthesis.
mechanical mitral prosthesis. Actually, the patient average age is 61. So in Asian population, there were very many portion of rheumatic pathology of mitral valve disease. So considering the patient average age, so over the 50 or 60% of patient maybe had the rheumatic mitral stenosis or mitral regurgitation. So they need just replacement rather than repair, because in rheumatic mitral valve disease, repair clinical outcome is not so good rather than replacement. So in Far East Asia country, still have many versions of rheumatic mitral valve disease. So we have to choose the replacement of mitral valve, and considering the patient average age, we have to select the mechanical prosthesis. So mechanical prosthesis percentage is around 60% in our study. So almost of all mechanical prosthesis implanted population have to take anticoagulation using the warfarin, and lifelong warfarin take. However, in case of mitral repair, they can just take 3 or 6 months anticoagulation using warfarin or coumarin. And after that, if they will show the atrial fibrillation recurrence after mitral valve repair combined maze surgery, maybe they need some anticoagulation or NOAC intake after recurrence of atrial fibrillation. So as Dr. Ellis commented in limitation in our study, the anticoagulation intake were not in very heterogeneous in our study population, and is a big limitation, because there are some patient got the replacement, some patient got the repair, and some patient showed the atrial fibrillation recurrence after 3 or 5 years. Actually, in our population, my clinical data analysis in South Korea Surgery Society reports from South Korea Society report, the 5-year atrial fibrillation free survival is around 70% after 5 years. So actually, the clinical result of maze in terms of sinus rhythm maintenance rate is very excellent. So, and the rectal atrial appendage resection using the auto suture or auto resection or auto suture device. So left atrial resection itself can make very big effect to the patient survivor and free thromboembolic event free survivor, I think. Yeah.
And it's great that you had subgroup analyses, and some of these findings were consistent across the type of mitral valve repair versus replacement and the pathology of the mitral valve as well. Well, Dr. Lee, I want to congratulate you and your group on a very fine real world study that I think is extremely thought-provoking and hypothesis generating. And Dr. Ellis, congratulations on your editorial, and thank you so much for providing your insights. It looks like that maze was only done in 58% of patients in concomitant, and all of our readers need to start thinking about more discussions with their surgeons and seeing whether we need prospective randomized data or greater implementation of arrhythmia surgery during mitral valve. Thank you very much to both of you for joining Heart Rhythm TV.
Thank you.
Thank you,
Dr. Tung and Dr. Ellis.